We're really pleased that you could join us this evening, and we've got a panel of experts that will be providing us some information, and then we'll have ample time afterwards for some questions and answers. Not yet joined us, but hopefully on the way, is Dr. Norman Oliver. Dr. Oliver is a physician and the Virginia State Health Commissioner. Next would be Dr. Nicole Holt, who's an epidemiologist and assistant professor in the Master of Public Health program at Eastern Virginia Medical School. Followed by Dr. Robert McNabb, who's professor and director of the Dragas Center for Economic Analysis and Policy in the Strome College of Business at Old Dominion University. Dr. Viola Von Eden, who is associate professor and PhD program director with the Eplin R. Strong School of Social Work at Norfolk State University. And Dr. Jordan Asher, who's a physician and chief physician executive, senior vice president for the Centera Healthcare System. So I don't see that Dr. Oliver has joined us yet. The commissioner must be running late. So if you don't mind, Dr. Holt, we'll get started with you. Thank you again for joining us tonight.
All right, good evening. Thank you, Dr. Martin. So during my time, I just want to provide viewers with a general overview of social determinants of health and just a little bit of context to process the information that's provided by our panelists. Currently, it's really critical to have an understanding of the social determinants of health and how COVID-19 impacts the health of both individuals and populations. So just by observing, we can see that health is variable, not just between individuals, but across different populations. So for example, in the United States, you're going to see two neighborhoods that are really only separated by a couple blocks have drastically different life expectancies between them. And this difference in these health outcomes between populations is what we call health disparities. And most of the factors leading to health disparities are preventable. So to answer the question why there is so much variability of health status between populations, we first must really think about the factors that can influence health. And these factors are determinants of health. These factors can include age, sex, genetic makeup, behaviors such as smoking, alcohol use, physical activity, and diet. Beyond these individual determinants of health, there are largely influenced beyond the conditions by which people are born, where they grow up, where they live, and where they work. And these conditions include their social and community networks, social, economic, and cultural and environmental conditions. And
recording has started.
Broadly, these factors are called social determinants of health. And these main determinants of health are listed here. The first one is economic stability. This relates to employment and income and other financial issues. Then we have our neighborhood and our physical environments. Here we're talking about safe neighborhoods, access to transportation, access to clean water. Also, food is another factor, such as food insecurity and access to healthy options, such as maybe living in a food desert. And then we have education. These factors include literacy and education all the way from early childhood into adulthood. Then there are healthcare system factors. We're looking at insurance coverage, accessibility of healthcare providers, and the quality of care that people can receive. And then finally, we have the community and social context. How connected is an individual in their community? And there are many different social determinants of health working across many different levels. And we see these complex interactions between them. And it really creates a web of factors that impact an individual's or a population's health. In the end, all of these factors impact health outcomes, such as morbidity or mortality, life expectancy, healthcare expenditures, just to list a few. And so we can begin to imagine the incredibly complex interactions of social determinants of health and how COVID-19 is impacting our most vulnerable groups in society. So for example, let's just look at one determinant, economic stability. So Let's think of an individual being unemployed. So now food insecurity becomes an issue. The individual no longer has money to purchase groceries, and so they're relying on community food pantries. Then we instruct people to stay at home, but what if home is not a safe place to stay? What if they're homeless? Then we have education. The digital divide is real and prevalent within certain populations and has a huge impact on the resources available for education. Also, does the individual have health insurance to seek testing or to seek care? What about the fear that some populations have about seeking care? Or what about the ability for them to find care without bias? And what happens is we begin to see this complex web of factors that really begin to influence one's health. So we've seen that the social determinants of health have a considerable impact on transmission and outcomes of COVID-19. The coronavirus did not create these health disparities. All it did is shine the light on them, giving us the opportunity to address them now and moving forward to ensure that everyone is able to live a healthy life. Each of the panelists this afternoon is going to touch on how the coronavirus disproportionately impacts the health of our most vulnerable populations and how the coronavirus has and will impact these social determinants of health. Thank you.
Thank you, Dr. Holt. Next, Dr. McNabb.
Thank you very much. And I believe if I am successful, everybody should see my presentation now. So as I proceed forward, I just have a few amount of slides and to illustrate essentially what is going on with respect to COVID-19. And so we want to talk about disparities in public health that arise from disparities, for example, in income. So if we look at the red bars here measure median household income in Hampton Roads relative to the Commonwealth of Virginia and the United States. And what you could see immediately is that the median white household in Hampton Roads, for example, in 2018, earned approximately $77,000 relative to the median Black or African American household that earned approximately $46,000. Now, you can see that Black or African American households in Hampton Roads actually outperformed peer households throughout the United States, but underperformed peer households in the Commonwealth. And so you see first we have inequalities just in median household incomes across different races, regardless of the level of education that the household has. What does that mean? If we have inequalities in income, that means we'll have inequalities in wealth creation. And we have two slides here, just very, very starkly different outcomes in terms of median and average net worth. So one way to think about this is the median is sort of the middle and the mean is the average, right? And if we're in a room and we just have the middle person, right? You're looking there and you rank them up and you say, okay, who's in the middle? And you could take the same ranking and Bill Gates walks into the room. The median person doesn't change very much, but the median wealth, the mean wealth, the average wealth just skyrockets, right? Everybody is now on average a billionaire because Bill Gates has entered the room. And when he leaves the room, everybody becomes dramatically poor. So we look at what's going on with the median and the mean. So here you could see there are stark differences in net worth by race. And those stark differences are by a factor of 10 in the most recent survey by the Federal Reserve with regards to the median household. And then on average, you could see they're roughly stark also, but that's because we have an income distribution that is relatively skewed towards the top end. So you have some very, very rich people pulling up the net worth there. What does that mean? That means if you look at the economic impact of COVID-19, you see that manifesting itself first in unemployment. And so here you can see what's happened to the trajectory of unemployment by race nationally just in the last 2 months. You see that Black African American unemployment jumped from approximately 5.5% prior to the onset of COVID-19 in the United States, and is now over 16%, 17%. And we believe truly that these are underestimates because these don't account for people who are working reduced hours and don't capture gig employment well also. So you could think of these as sort of lower bounds on the economic impact in terms of employment in the United States. Well, what does that all come out to mean? Well, COVID-19 has disproportionate impacts. So far in the United States, if you look where it has occurred, it's occurred primarily in denser, more urban areas. And in fact, the cluster of COVID-19 cases and deaths in New York City is greater than almost all the states by themselves in the United States. And so if you look at the distribution of the US population, that means if you have more of the prevalence of COVID-19 in denser urban areas, you're going to have a higher proportion of individuals who are minorities that acquired the disease and tend to have worse mortality outcomes. And so we have to be very cognizant of the fact that as we receive more data, we need to track this data very well to understand not only what is happening by race, but what's happening down to race by income, by race by employment status, etc., because these are very tough questions to unravel. It's also an unemployment or an employment crisis that's unfolding in the midst of a public health pandemic. And so you see that not only have we seen a spike in unemployment across the nation, we've seen a disproportionate impact of unemployment in non-digitizable industries. And what does that mean? Well, if you're looking at this on Facebook, you're taking part in a digital presentation. And so that digital presentation allows you to partake in something that 10, 15 years ago, you had to be in person. Now imagine that's your employment. If your employment means you have to show up physically to a location, you can't do it from your house, you're more susceptible to economic disruption than somebody who could just pick up a laptop, go home and work from home without much disruption. And so what we see is that there appears to be a higher concentration of Blacks or African Americans in non-digitizable or lower digitizable industries. And so if you combine the employment shock with the fragility of those households in terms of lower net worth and the COVID-19 impact, you end up with disproportionate impacts that we should all be very concerned about. And this manifests itself in higher stress and also lower levels of health over time, but it will be more damage in terms of wealth accumulation and set these households further behind white and Asian households over the next decade in terms of income and wealth accumulation. Thank you.
Thank you, Dr. McNabb. That was very informative. Next, Dr. Von Eden.
Okay, I'd like to also share my screen with you. So when we think of some of the vulnerable populations and the issues around education, we realize that it's been quite overwhelming, I think, for everyone, but especially for our children. And in part, we look at some of the topics related to food and shelter, educational resources, how parents and teachers are addressing or trying to manage with this stress. And you've heard from Dr. Holt and Dr. McNabb some of the things that I'm going to say, but I want to reiterate them, specifically how they address educational needs. and realizing this is very short and very brief. One of the things that I found very overwhelming, and of course I am a social worker at heart as well as being a teacher, but is how many children are going to go hungry. So I recognize the need for people to be safe away from the virus. But my first thought were how many children who only receive meals at school are going to go without. And many of you may have heard that there are backpack programs in our community that actually send food home for children on the weekend so that when they're not in school, they're receiving meals. But also, my area of specialty is child abuse and neglect, and I won't belabor this, but I'm sure you've noticed in the news the increase of child abuse and neglect, more severe reports, because what's happened, on one hand, reports from day-to-day, more minor forms, and I don't want to minimize abuse on any level, but day-to-day reports that would be coming from teachers, now that children aren't being seen in the school setting, those reports aren't being made. But what my colleagues who are physicians are telling me is that by the time the report is made, the severity of broken bones and other more extreme abuse is what's making it to their offices. So it's troubling because we have to realize that school isn't just a place for education. It means so much more. For our college students, the struggle has been homelessness, and being at a university, I think it's quite shocking for people to know that many of our college students don't have a home to go to, that the university was their safe haven, so now they don't have a safe place, as well as many students, high school and college, have lost jobs in the course of this pandemic, and what that means for them as well, because they were either supplying resources for their household, or they will not be able to return. So from an educational resource standpoint, however, another major issue has been the lack of internet, the lack of laptops, and then the technical and connectivity problems. For many of us, we realize that our students, just like us, were not really prepared to be online. And so there's been a real distribution issue for coursework, for educational purposes, as well as for technological purposes, and continuing for children to receive what they need. And school, of course, is a big area for socialization. Parents are overwhelmed. I'm a clinical social worker. I do counseling for parents and children. Parents are overwhelmed. They're trying to do the best they can, but many of them don't have the educational training to provide or teach. The famous joke of, I don't even know how to teach my fifth grader the math, the new math. But that's a real issue and a real problem. They also have to recognize that through being overwhelmed and trying to parent, they're not either able to go to work because their child is now home, or they have lost employment. And I know both Dr. Holt and Dr. McNabb touched on some of these issues. But I think one of the things that we have to consider is ways in which to support teachers as well. Teachers themselves, in the course of trying to provide education, are finding themselves without proper instruction on how to teach online and the resources to do an online curriculum, which is very different than the day-to-day face-to-face curriculum. So some of the recommendations that I would make as both an educator and a social worker is that we have to have some opportunities for child welfare workers and school social workers to do wellness check, but they have to be able to be safe in that process of doing it. We also have to have some trauma-informed care and services, telehealth services for helping families manage the stress and anxiety, and just general education around what COVID-19 means. There's a great deal of information online, but there's a lot that's very incorrect. So how do we support people who are grieving on numerous levels as well as helping the children manage something that none of us have ever experienced before. But through that process, we also need to have trauma-informed teachers and educators. I can't tell you the level of anxiety that was experienced by many of my graduate students who are master social workers learning how to be clinical therapists, how they were struggling in the course of their own education as well as supporting their children. So one of the things that we would need to see is in this process is some coping and cognitive skills building, because learning when you're stressed out is very challenging, as well as you've heard Dr. McNabb and Dr. Holt both mention a reduction in poverty. And I will go out on that limb and say that boils down to universal minimum standard of living, universal educational resources, and then universal health care. We've seen it work in other countries. I think overwhelmingly we have to do something very different as we go forward. So thank you. That's all that I have.
Thank you very much, Dr. Ronnie. I see Dr. Oliver has joined us. You're noted there as guest, and you certainly are a guest, Dr. Oliver. We appreciate you being here. We'll go ahead and, if you're ready, we'll go ahead and move on with your presentation now, and then we'll join with Dr. Asher after that, if that's okay.
Yes, thank you. Can you hear me?
Yes, sir.
Okay, I'm not exactly sure how I go about sharing my page here. I have a few slides I'd like to show. So let me see.
Can you walk Dr. Oliver through that?
Yes, sir, absolutely. Dr. Oliver, at the top of your screen, there is a button that looks like a screen.
Okay, yes.
Just click on that button and choose what you would like to share for us.
Okay.
Excellent.
Okay, so great. So you all can see that slide then?
Yes, sir.
Okay, great. I'll try and I came in late. I was at another meeting. I apologize. It went over time. And then, but I finally figured out how to join you. I came in on the middle of Dr. McNabb's presentation, which I greatly appreciate. I think it hits at a lot of the points that I had wanted to stress about the real causes for the kinds of inequities that we're seeing with COVID-19. I wanted to just tell a story, however, about, if I can advance my slide here. A patient that was in one of our health districts. We have 35 health districts around the country, around the Commonwealth, and in far Southwest Virginia, we have, as you well know, a major problem with opioid epidemic there. And I'll tell you about someone named who I'll just call Christine, who young woman who was addicted to OxyContin. Came into our local health district there wanting to get off of her addiction, enrolled in a program for medically assisted treatment for her addiction, was treated by our clinician there, was able to get off of the medication, off of the narcotic. However, Christine lived in a household with her grandmother. She was essentially homeless and was sort of couch surfing, and at that time was living with her grandmother, and in that house were a number of other people, a number of whom were still users. Christine was pregnant and decided that she really couldn't stay in that environment, so she went to her local sheriff and asked the sheriff to put her in jail in order to keep her out of that household so that she wouldn't relapse. The sheriff, being a kind soul, jailed her. She was jailed for her entire pregnancy, had the baby, at which point the sheriff said he couldn't keep her in jail with the baby. So she went back to grandma's house, wound up one thing leading to another, back on narcotics, baby taken in by social services, And there you have it. And I maintained, as we learned from Dr. McNabb's presentation, that this is not a problem of narcotics, but in this case, it's a problem of a lack of decent, affordable housing that she didn't have because of her economic situation and her social situation. And it's dealing with those sorts of things that I think are really important. Public health, the Virginia Department of Public Health has been in existence for about 112 years, I think, this year. In the first half of that history, we focused on things like ensuring that there was clean drinking water, looking at communicable diseases and the spread of those communicable diseases through the science of epidemiology, which is the study of epidemics, right? And what we found at that time, of course, was that most people were dying from communicable diseases. And that period of time where we focused on things like drinking water and sanitation and studying the spread of communicable diseases, we often talk about as public health 1.0. And what occurred, as you all well know, is that at a certain point, people were able to get a better handle on these communicable diseases. First of all, the clean water and the sanitation, and then after that, through the development of vaccines and immunization campaigns. And when we got a handle on it, what started to happen was that chronic diseases became the major killer of people, and we began to get involved in work around health promotion, disease prevention, and this is what we often speak of as public health 2.0. We also, in this same period, had to recognize that communicable diseases didn't disappear, and every now and then there was a new emerging disease that we had to take cognizance of and begin carrying out initiatives to help campaign, like AIDS or today, COVID-19. I believe that the kinds of things that you all have been talking about already in this panel about the underlying causes of social inequities is really, really critical. This cartoon is something that Tom Frieden, who is a previous head of the CDC, developed to explain in a pyramid sort of form, those things that have the highest impact on changing the public's health. And as you can see from this cartoon, the things that we focus on the most in terms of clinical medicine are at the top of that pyramid, the counseling, education, clinical interventions, but they have the smallest impact on the overall population health because of the sorts of things that Dr. McNabb was talking about. Changing the context of in which people live, dealing with the social, economic, and housing questions, things like that really have the biggest impact on those populations. I'm going to skip over this one. At the Virginia Department of Health, we have a thing we call the Health Opportunity Index, which is a compilation of a number of key factors that affect health along those lines that you all have been discussing. Everything from, economic well-being, poverty rates, employment rates, that sort of thing, transportation, and other key factors. And we put them into an index, and we've mapped that index across the Commonwealth. And we can get this right down to the census tracker, census block level. And we call this our Health Opportunity Index. And you can see that we have two Virginias here, with the South Side and far Southwest Virginia having very low Health Opportunity Index. And this correlates with important outcomes like life expectancy, which is much higher in the wealthier portions of the state and much lower in rural areas. And it's also true on a local basis. So if you look at Richmond City, for example, and I show you a picture of Richmond City with mapped at the census tract level with our health opportunity index, even those of us who are not from Richmond can readily look at this map where dark green shows very low health opportunity index. And even if you didn't know Richmond, you could tell me where the African American community is here, which is on the north side of town and on the eastern part of the city. And that, again, has an impact on important outcomes where Western, more white, more affluent Richmond has much higher life expectancy than areas on the east and north side of the city. VCU did a nice map of that same finding where you can see in Gilpin area of Richmond here, the life expectancy is a full 20 years less than life expectancy just a few miles away across the river. So that has an impact then on the health of that population. And it's not something that is rooted in differences in the susceptibility or anything biological. It's rooted in these social and economic factors. So I think that that is something that isn't often stressed enough, and unfortunately is reflected in the way in which we apportion our resources, so that you see that 95% of the investment in health goes towards things like direct medical care, when in fact it's these social economic factors. And I would maintain that even health behaviors are related to those social and economic factors. Whether or not you have a healthy diet is not just a matter of personal choice, but what you have available to you structurally in your communities with lack of good, wholesome food in many disadvantaged neighborhoods. So from a public health perspective, I think we have to begin looking at communities' assets, and then with that community developing a vision of where that community wants to go and improving its health and well-being, and look at that gap between those assets and what the needs of the community is in order to achieve that vision. As you well know, there's all kinds of people working in that space: state government, local government, community organizations, faith groups, many others. Unfortunately, quite often we work in silos. And one of the things that we've been trying to do at the health department over the last few years is to try to get all of those individual organizations and players connected to one another, coordinated, so that our individual activities become mutually reinforcing and increases our ability to actually close that gap in an effective way. And this is, as what some of you, I'm sure, are familiar with, a collective impact approach, and we've been able to partner with a number of organizations around this. I think that this is going to be very important with the COVID-19 pandemic, being able to respond to and effectively protect the Commonwealth from the ravages of this pandemic requires a whole of government approach across multiple agencies, and in our communities, a very large cross-sector response with, I believe, a health equity lens to that work. As you have been discussing, this is a pandemic, like everything else in our society, that affects different communities unequally. And those who are the most disadvantaged are the ones who are being the hardest hit by it. And I think our interventions need to be targeted and really pay particular attention to those communities, which are communities of color, the rural communities of the Commonwealth, and poor urban populations in general. I'm going to stop there so that we have some time for questions. Thank you very much for allowing me this opportunity to present.
Thank you so much, Dr. Oliver. And then last but not least, Dr. Asher.
Great. Thanks so much. I think I'm off mute. Yes, I am. I first want to thank Dr. Martin and EVMS for putting this on this evening, because I think it is such an important topic for lots of reasons. And I'm also very humbled to be with all of you, our co-panelists this evening, talking about such an important topic. And what I want to do over the next few minutes is really begin to tie this back in what we are seeing at Sentara in our different in our different areas where we are. I'm not going to be showing any slides, so if any of you are wondering, is there anything on there? The answer is no. You just get to look at me for the next 5 to 7 minutes. For those of you that might not know, and most importantly, thank all of you for watching, Sentara Health is an integrated delivery network providing care across the state, Commonwealth of Virginia, as well as North Carolina. And we are in many different markets, from Hampton Roads, Suffolk, Peninsula, the Blue Ridge area, South Boston, Harrisonburg, and Northern Virginia. So we've really been able to see what has been happening across the state in different micro ecosystems or microcosms. And it's been very interesting. Sentara is also very focused on delivering health every day to the communities we serve. And within that, really thinking about those communities, both from a equality and a health equity standpoint. And so we have become very focused on what we need to do to get out into the communities that we serve and really provide the care, not only health care, but to the points that were made, especially Dr. Oliver. In order for me to really take care of people, I need to focus on the 80%, not the 20%. And what does that mean? And how do we in healthcare really change our focus to delivering health, which is markedly more than just healthcare itself, to create healthier people? So thank you very much for that. So as we began through this crisis, and I am going to call it a crisis for lots of reasons that you've already heard, we very early on began to think about the community. Obviously, at the very beginning, testing was hard, but when we began to have the ability to test, we decided to go out into our communities and test. And interestingly enough, what we found in those early places, that we were effectively testing just like the population looked like, but what we also realized is that we weren't getting to those that from a disparity standpoint. Unfortunately, because testing was not available at the time, we had to back off of that, but that story does change. But what we did notice, and I do want to share some numbers because I think this is very important. We've been talking in sort of the high level. Now I want to talk about what we saw as we began to collect data. And what we saw, and just on our inpatient, that Black patients had a 2.7 times greater odds of having a positive test compared to white patients. And so these are people that became admitted, which is statistically significant. Hispanic patients, because 2 of our communities are in heavy Hispanic areas up in Northern Virginia and Harrisonburg, they had a 5.4 times greater odds of having a positive test, once again, statistically significant. Now, for us, we did not see any difference in mortality rates at our hospitals, but I do have to couch that in the fact our overall mortality rates have been fairly low, even though we tend to run a census every day of about 120 to 140 COVID positive patients. In our ED populations, we also saw a statistical difference in the Black population being 1.4 times higher. And once again, the Hispanics markedly elevated at 6.9 times higher of having a positive test through the emergency department. And then in the outpatient arena, there was no difference. But that tells you something, because as we talked about, what that told us was A, we're not getting to these people and they're not coming to the doctor to be tested. They're waiting to get their care in the emergency room, which goes to some of the conversation we had earlier. And so that really made us step back and think and moved us on our journey towards how do we get to those communities that really have health disparities and health determinants, social determinants, as Dr. Holt talked about earlier, that really are important. And so we put a model together working with the VDH, Dr. Oliver and your department, Dr. Underwood at the state to say, okay, we now have the testing capabilities and we have this desire. Where do we need to go to provide testing in those areas? And since we began all of this, we've tested approximately 30,000 people, and in these community areas, we're up to about 2,000 that we've done. That number does not sound large, but it's very impactful from the standpoint we really focused on looking and thinking about living units that were talked about earlier, and trying to find symptomatic people in those living units as an idea of what it was, of what the not only the prevalence, but the illness of what was going on. Since the late, I'm losing all track of days and time. Someone tell me what day of the month it is. But for the past 3 or 4 weeks, we have visited over 25 different communities to do this. And I now want to talk about some of the learnings that we had and we're having as we go through this. We were really trying to get this done, and we went to our first place and only had 8 people come for testing. And that really said, okay, we're doing something wrong. Even though we're so focused on health disparities, even though we're trying to go to the communities, even though we've been doing this through faith-based organizations, what is happening? And so we really stepped back and decided to really say, okay, what should we be doing differently? And we learned a couple of interesting things that I really want to share, because it really gets to Dr. Holt, what you were talking about early on about those determinants of health, but I'm not going to talk about the clinical determinants. I'm not going to talk about race and color. I'm going to talk about activation and engagement and why people were staying away from being tested when we were coming to them, because I think it's incredibly important for this conversation. We found a lot of fear and stigma that when we went into these communities, there was a great fear that we were coming to do something to them versus to help them. And obviously, Centera is very focused on providing care, but we very quickly had to learn that we had to work within the context of the health determinants that were happening in each of these markets. We spent a great deal of time working with trusted leaders from those communities, even to the point of them having to be tested in front of others in order to create some of that trust. We also learned that messaging was everything. And so when we talk about the top of your pyramid, Dr. Oliver, the idea of education is completely, in my opinion, wrong as we think about it, because I educate in the way I want to communicate with you versus helping you understand what is going on in the language, and I put that in quotes, in the language of how you hear it, and that messaging becomes very important. So we had to move away from terms like surveillance. We had to move away from terms like using the word study or anything like that, because that engendered all types of thoughts. Another point that my esteemed colleagues made was around technology. And we also found that we were having a very difficult time getting information out. I'm not talking about education. I'm talking about even information around the testing because of the technology gap. Because we thought we're thinking in a digital age where, oh, I'll just send out emails. I'll just put something on Facebook. Obviously, everyone's watching. But we quickly realized that that was not a mode of communication that worked for the people we were really trying to get to. And so we very quickly pivoted to working with the local trusted leaders and using their ability. The faith-based community was unbelievably helpful with this, using their lines of communication and basically saying, hey, we're here to serve. How do we do it through yours? The other thing we found is we had to be very careful about who we brought with us for testing, meaning that every community we went into wanted to provide security and just to make sure cars were moving the right way. We learned very quickly that if we really wanted to do what we wanted to do, we had to make sure there was no security or no police cars. People were very scared to come. There was a huge concern about deportation when we show up in a white van to try to provide services. So we even had to change. The other thing that became very important was what are the other wraparound services that we had to provide at the same time. So to the point earlier that the social determinants lead to worsening conditions, which lead to worsening situations, comorbid conditions, we also used it as an opportunity to try to provide those other services or what they need. Face masks, food, information in the language and way became very important. And so the real takeaways for us is that we have to make sure we think about it within the context if we really want to impact those social determinants and not think about it from sort of the supply side, meaning I am here to supply a service, here's my service, versus the demand side is what do you need? What is the problem you are trying to solve? For instance, people did not want to get tested because they didn't want to be told they were positive because then they couldn't go to work. So how do we help solve that problem? Because no one wakes up in the morning saying, hey, my job is to figure out how to stay healthy today. Everyone wakes up saying, how am I going to take care of my kids when I have to educate them at home, where the whole reason I sent them to school is so I didn't have to take care of them because I can't do that. That's not my set. How do I pay my bills? How do I get food on the table? And so it really began the key for us, and we knew this going in, but it really played out in life, is that we have to focus on solving the problems that people have within the context of their environment, the social determinants that we talked about earlier. Working and listening to the trusted voices in the community. Really getting away from the idea of, hey, this is what we should do, versus saying, here's what we can do, and this is what our why is and our focus is. You tell me the best way to do that. And as we did this, our numbers went from 8 at the first time to now, as we continue to do this, unbelievable numbers of people that are getting tested. And interestingly enough, depending where you are, Dr. Oliver, some of our positive rates in these communities have been as high as 40%, some as low as 0, to talk about the difference in areas once again, but averaged around 11%. And these are people that had no intentions of going to be tested. And these, with the tracing, were in family situations or living situations where it impacted a lot more people. And so I really just wanted to take a few minutes to share with everyone sort of the journey that we saw as it relates to this public health and medical crisis, what our learnings were, and how important the engagement and activation was within the social determinants that were talked about. Thank you very much.
Thank you, Dr. Asher. That was excellent information as well. Everyone, panelists, I want to thank each of you for that. I know that it's being enjoyed by lots of people online, and so now we'll move to a question and answer session, and Sherwin Watkins is monitoring the Facebook live feed and will feed us questions from it, and then whoever feels like they can answer the question best, one or more, will jump in. Sherwin, did you have questions?
Yes, I do. It was hard for me to unmute myself. Sorry about that. But good evening. I do have a first question that came in. And the question is, how can government normalize conversations about inequalities? How can communities encourage elected officials to center health equity? And anyone can jump in if they want to answer that question.
I'd love to start just a little bit. I think it's by us continuing to talk about it. I am new to this area, and even in the first 2 years I've been here, I've really watched. By the way, when we say the government is really us. And so we own this as everyone that is watching. And with the Commonwealth, with Dr. Underwood and the work that is going on, I think there is a focus. To my comments earlier, we have to do it differently, though. We have to think about what do we need to do to get people over the fear and stigma of even the fact that I am here as the government to help you, right? That is not, in my mind, how we need to focus. Very much more of how do we raise our voice together and really say, yes, there are inequities. Yes, things have happened. And yes, we want to do better and working together to solve that.
I'll give a shot. Two things to recognize. First, much of the discussion with regards to inequities from an economic perspective are framed in what we would call the domain of losses. If we decide one group should have a more equal say, people say, well, that must mean somebody else has a less equal say. Other than to recognize that if one group is severely disadvantaged, that creates problems for society writ large in terms of economic growth, in terms of social stability, in terms of public health, and so forth. If more equal societies in terms of an income distribution tend to be more stable, more democratic, and tend to grow faster over time than more unequal societies. Now, some people will say, well, that means you're talking about a massive redistribution of wealth. Our tax system does a massive redistribution of wealth. Right now, for the last 40 years, that massive redistribution of wealth, whether you like it or not, the public policy decision has been skewed towards the top end of the income distribution. By the way, just politically, I'm a fiscal conservative. I've voted Republican most of my life. I'm just saying a public policy objective statement. There's no disagreement on that, the way we've changed our tax system. So if we have changed our tax system one way, by political will, you could change the tax system another way. It's a matter of preferences and political will, if that is important to the American people. And I will echo the comment. If people get out and vote, things change. If people don't get out and vote, those who vote, well, policies reflect their decision making. So if older people tend to vote and older people want to retain their wealth, then you end up with systems that help them retain their wealth and transfer their wealth, vice other types of systems you might want. So it's about democratic process, democratic participation. And it seems like a cliche, but if you don't vote, it's very hard to have a voice.
Okay. Did anyone else want to chime in? Or I can move on to the next question. All right, moving on. This question comes from Aztec. And the question is, what and when are we going to take action instead of continually talking about what the problems are?
So this is Dr. Oliver. In addition to the call for us to get out and vote, I think it's also, I'm a child of the 60s, and I think back to the civil rights movement and the anti-Vietnam War movement and things like that. I believe that people who are the most affected by this crisis are the ones who need to take some social action along those kinds of lines to help convince those of us in government to do the right thing. I would encourage Aztec and others like Aztec to become activists in on their own behalf and speaking about, as someone said in the panel, pushing forward their demands. This is what we need in order to address the problems that we're confronting. And in that way, get some action. That combined with the voting, I think, is what will make it happen.
And for me, and I appreciate the question and the comment of what and when. And what I don't want to happen, and what I do is that we think about this only within a time of crisis. And so how do we make sure we continue that work? And very specifically for the what are we doing is we are building our next things that we want to do in the health equities based on the learnings that we are getting from this. So this is not a one and done situation, and completely agree with you that it should not be. And so we are already thinking about what we are finding as we're going out into these communities. What we see when they come into our places of healthcare is saying, okay, how do I change that completely? For example, even though we talked about technology problems, I'm sure all of you are aware because we're doing this by video, telehealth has ramped up a huge amount. So instead of saying, oh, how can you connect with me on the computer? It's how do I get those computers to you? How do I take them and make that mobile telehealth situation for the other healthcare issues that are going on? So really, we have to think differently. And I do believe that those of us in healthcare historically have thought in certain ways. And we have to stand up and say, not only please tell us, Dr. Oliver, to your point, but also please understand that I need that help in helping to know and what are the ways where that works, and then continue to make progress.
So I'd like to add as well to the conversation. I think one of the things that is so important to realize is the grassroots efforts and how important it is. I think oftentimes we look to larger systems to guide us. And I think one of the things, if COVID hasn't taught us anything, it's taught us that we have some major failings in our infrastructure on large scale levels. But if we think back to when movements really made a difference or made a change, it was the small groups, the small group efforts, the grassroots, those people that take charge within their own community. One of the things that we mentioned is the lack of laptops, in particular for students, and even high school students, children, as well as college students. One of our recent graduates, a master's graduate, has what's called Hope U. And his nonprofit small group made sure that they distributed a certain amount of Chromebooks for students that didn't have it. Were they able to give one to every person in the community that needed? I'm sure they weren't. But the few that they were able to get to made a difference for those students. And I think we can never minimize the efforts that a small group of people can make. I was so amazed at how many churches were already live streaming their services. But so when it went to COVID, it wasn't that difficult. And right as the pandemic was starting, I and a colleague were invited to speak at a church, a Baptist church up in New Jersey. And what amazed me is how the church came together around some parenting training. But more than anything, I was able to learn how their outreach in their community was supporting those that were even more or less fortunate, whether it's through food, identifying shelter, identifying, clothing, any of those things, because they're all needed. So I don't want us to wait always for the larger infrastructure to be repaired, but to do as much as we can do on a grassroots level.
Thank you. Okay, the next question comes from Tiana Jones, and her question is, how are minority groups recovering from the crisis of COVID related to medical expenses or aftermath outcomes?
I guess we all shouldn't speak at the same time, huh? Um, I don't know yet. Obviously, we see this as a problem continuously. I think, at least around COVID and the payment for COVID care is pretty much now a requirement. And we are obviously during this time focused on treating all in need, regardless of the ability to pay. And I think it's really going to be, as we come out of this, as I spoke to earlier, how do we continue, but also how do we work together as a community? And how do we make sure that the different aspects of the community that feed these or help with these types of situations, funds, whether it be Urban League, whether it be LISC, we have a partnership with LISC which hopefully can pivot and focus on these types of issues. To Dr. McNabb's point around the financial component, because not only are we going through a financial hardship now with the economy and the unemployment, but when you layer on top of that the possibility and fear of healthcare bills, I think that's going to be incredibly important. And as we talked about those things that we should be thinking about and doing, and then advocating for, it is exactly that type of comment, and not just look at this as an episodic situation, but one that we're going to have to solve for in lots of ways going forward.
If I may, my largest concern right now is with respect to, as states reopen, the expectation at the federal level may be too aggressive with recovery to the labor market relative to unemployment benefits. And so right now, under the CARES Act, we see an expanded set of unemployment benefits, not only for people filing for regular state benefits, but people who typically would not be able to file, contractors, gig workers, etc. Those will run out for some people midsummer and or earlier. And there's another program, but that will run out of money quickly too. So the expectation that we've done enough is probably insufficient, because what we know in terms of recoveries from recessionary outcomes is that these take years and they have detrimental impacts upon lifetime outcomes and wealth creation. And if you start off in a relatively poor position, you're going to probably lag behind other people who've come through that recessionary period better. And so this kind of loops back to discussion of, we have an unemployment insurance system that's designed for a labor force that doesn't exist anymore. That was primarily on the manufacturing floor, that was primarily high school graduates or less than high school graduates, skilled labor. That factory type of American mythos has changed over time. We're much more transitory in the work. The nature of work is evolving. It's much more contract oriented. We need to talk systematically about what that means for our social safety net. And one last point, back to the question about how can we change things? The simplest way to change is to go to your local government and look for a vacancy on a commission or agency or local board. And you'll find, surprisingly, in many cases, that there are many seats available, and maybe there's something you're interested in, a housing board, a recreation board, etc. Get started there. Figure out how local government works, where the rubber meets the road, and you could actually have an impact. And maybe you like it and get involved in politics, or maybe you go, whoa, I never want to do this again. But just that a little amount of time every month is part of the way things change. And I know this from being a school board member and having sat through school board meetings where you're making decisions about students and budgets and there's nobody in the audience. So just being engaged makes change. I hope that helps.
Thank you. Okay, moving on, we have another comment and question, and this comes from Vincere Atamori. And the comment is, we must begin to reevaluate our response based on the emerging data, adjusting our approach based on what the data is telling us. The question is, what type of test should be focused on at this point? Is it reverse transcription, polymerase chain reaction, or the rapid antibody-based test?
So I'll let the panelists from Centera chime in on this as well. But from the public health point of view, I think it's important to realize that those two tests test different things. So the molecular test, the PCR test, as it's called, is a diagnostic test that lets us know whether or not you have the virus in your body and replicating itself, and picks it up when you have a certain amount of that virus in your system. We get a specimen with the nasal swab, and we grow it in the lab so we can pick up some of its trademark markers, and we can say you have that virus. And we can say that whether or not the virus is giving you symptoms at that time. The blood test that looks at antibodies is a test that lets us know whether or not you've been exposed to that virus sometime in the past, and your body mounted some kind of immune response to that. It's currently unclear to some extent whether or not that antibody response is permanent. There's different antibodies. There's an antibody that we pick up that lets us know that you may be currently having an infection, and that first generation of antibodies, or IgM antibodies as we call them, are being mounted to try to fight off that infection. And then later on, you develop IgG antibodies, which with other viruses is an indication that not only were you exposed to it, but you successfully beat it off, and now you're immune to that virus. The problem with this virus is you've heard us speak about it as a novel virus. We haven't seen it before. We don't know how it operates, and the data out there is unclear right now about what our immune response is to it. There's been some indication that the IgM and IgG antibodies occur relatively close to one another. There's been some literature that indicates that people who have had the disease get it again. There's been case reports of that happening. The serology test or blood test would be something you would do to see whether or not someone has had the disease already. And it may play an important role, for example, with this new pediatric phenomenon of the multi-system inflammatory syndrome, where children get this multi-organ inflammatory disease that seems to be a post-infection response, having gotten over the COVID-19, and then they have this thing. So antibody tests might be able to play a role in helping us deal with that phenomenon. And there's other things that it could probably help us do.
Yeah, I completely agree. And just as the virus itself is novel, we also have to step back and remember we've only been focused on testing or even figuring out how to create tests to test for it in lots of different ways now for 3 months. When you think about it, that's a very short timeline. We're also learning all types of other things about these tests, whether it be the PCR or antibody serology testing. Is not only is the IgG and IgM happening at the same time, it is lagging by a week or so in when your symptoms start. And the PCR testing in an asymptomatic person doesn't necessarily pick it up. And then to boot, to make all this even more complicated, we hear about testing. Even in your question, you asked a bunch of different types of tests, and we're all learning. It's sort of like, what's the best flavor of pizza with all the different toppings that we all really should like and know. We just don't know yet. So I unfortunately don't have the perfect answer right now. However, from a diagnostic standpoint, the PCR test, when you're symptomatic, is likely the one that's going to tell you that you have active COVID that is causing problems, which from a treatment standpoint is very important. From a prevalence or looking at it across a whole population and where we are in it, I'm not sure we know that answer yet. I think we're going to be looking at antibody testing. We're going to have different we're going to have all types of different testing coming out. I think the key is when you don't know is to try to do as much as you can and learn as much as you can, and just realize, unfortunately, we tend to be a country where we want a specific answer now, today, and we just don't have that in the science. I can say as someone that has been dealing with science my entire career and watching it in the past, I am unbelievably amazed at how quickly we are moving as a world learning about this and coming up with new tests every day and how that is coming about. We don't know yet if what we're testing, as over time, if it's just a neutralized virus, meaning that I'm still being able to test some of the proteins, but it doesn't impact, it's not impacting anything. And I think this is going to become more and more of an issue as we try to open up, and then everyone's going to say, well, just get tested, and that way it's a safe place. If you come to me and I test you and you're negative, all I can say is that you are negative today at the time I did the test, assuming it's not a false positive test. And so I think we're just going to continue to learn. I think we have made great strides in the number of tests for the Commonwealth, and there won't be a good answer for your question, I would say, for a little while.
Okay. Yeah, I think you touched on some of the next questions coming up about your degree of confidence with the test being administered to check for COVID-19 and also for the antibody. I don't know if there's anything else you wanted to add to that, but I think you've touched on it. So I'm going to move forward. Another question. Based upon Dr. Asher's lessons learned, will the expertise of social workers be used to inform how best to approach, disseminate information to communities of vulnerable populations?
Do you want to go ahead, Dr. Asher? Or?
No, I was pointing to you. This is your area.
Okay. I actually missed one of the words that you said for some reason. Could you?
Do you want me to repeat it again?
If you would, because
Sure, not a problem. It says, based upon Dr. Asher's lessons learned, will the expertise of social workers be used to inform how to best approach information to communities of vulnerable populations?
Okay. And exactly. And, it was really interesting when we were listening to Dr. Asher talk about the experiences of going into the communities, because that is exactly what we're teaching our social work students, that they have to start where the client is, essentially, is kind of what we say. But part of starting where they are is asking them what they need. We really all struggle with wanting to help so much that we forget that they're clear stakeholders in a community. They're clear leaders that will community members will follow. And if we don't start there, then we are missing the boat. So I found what happened when they first went out to be really interesting, and certainly will continue to share with our students. But that's it. We have to start where they are, and we have to recognize. I actually took a few notes when he was talking to go back and share that there is no doubt that we have to listen to the trusted voices in the community, that we have to recognize the faith-based organizations. One of the things for some of you to understand is in social work, Norfolk State actually has 3 levels: the bachelor's program, the master's program, and then the doctoral program. The doctoral program is simply teaching people to be educators, but the bachelor's program is really focused on casework, going into social service agencies, where the master's program has a clinical focus and teaching a lot of our students to be therapists in the community or leaders in their agencies. But the information that we really try to strive on is about general practice within the community. So it's part of their curriculum and it's part of their competencies that they have to. And the last thing I will say to you all, for social workers, especially like the master social workers, they have 15 to 18 hours of field education. Now that's a week. So that, and for the entire 2 years of their master's program. So that has been a challenge with COVID-19, but we have been working diligently to make sure they continue to have those experiences.
Okay. Thank you. Okay, moving forward, this question comes from Bernard Larry Hill. If and when there is a vaccine, will there be a priority of who may be vaccinated first?
So from the public health side of things, our Division of Immunization is already mapping out plans for a really massive vaccination program across the Commonwealth. We during the last pandemic, 2009, 2010, H1N1 flu, we received millions of doses of vaccine. We distributed it through a state system to private providers, hospitals, and so on. And the health department itself set up what we call points of distributions throughout the state that allowed us to do that in over the course of one season, a fall to winter season. And that's our plan for dealing with the vaccine once one is developed for COVID-19. So in terms of prioritizing, I think that our plan would be to really, in very quick order, ensure that 80 to 90% of the adults in the Commonwealth are actually vaccinated against this, and then we'll have to see what the vaccine's characteristics are like for children and make a plan accordingly. So I don't think that the plan would be to in the same way that we had to do it with testing, where we had limited resources and we had to figure out a way to target our testing. I think with the vaccine, it's going to be a plan to vaccinate virtually everyone against the disease.
Well, Dr. Oliver, I have another question for you. The question is, are you worried that a second wave of COVID-19 will come as Virginia relaxes the restrictions?
I believe that as we relax the restrictions, that we will see an increase in cases. And for that reason, we have mapped out a pretty aggressive campaign of identifying cases when they develop, looking at their contacts and who they've exposed to the virus, identifying among those contacts anybody who is symptomatic, and with both the cases and the contacts, isolating them and quarantining them so that we can tamp down the spread of the disease as we open up. We believe that if we do that in a really rigorous way, that we'll be able to weather the increase of cases that we'll see in such a way that we don't overwhelm our hospital and healthcare systems. If the sort of models we're looking at, if we do that through the summer into the fall, I don't think that the relaxation of the social distancing and other restrictions that we've had will generate another big spike in the disease. That being said, the virus is still out there. Again, we've never seen it before, so we don't know how it acts. We don't know whether there's any seasonality to it. Is this like the flu, something that will rise again in the late fall and early winter? That is certainly a possibility, and I worry about that. I can't say that it will absolutely happen, but there's the possibility we could have another wave of COVID-19, and there's the possibility it could happen at the same time that the flu season starts up, which would really be a challenge for us to deal with, especially if we don't have a vaccine for COVID-19. I think having gone through this first wave, however, we're much better prepared to deal with the second wave should it arrive.
And I could not agree more. And I also want to reiterate that last point. We think about another wave, or we think about continued COVID, and we think about it in the context of a light switch, turning on and turning off the economy, or closing down. Are we going to have to? The real reason people are asking that to me is, Jordan, does that mean we're going to have to close down again? And that, because of everything we've talked about, I don't think that is a realistic thought, and I don't think it has to be a thought in the fact that it causes harm as well. And what we have been able to do is buy the time to prepare. So as a health system, we're very much prepared and realize we're going to be taking care of COVID patients for a while, sometimes higher levels, sometimes lower, but more importantly, we also have to take care of everybody. There are plenty of people that had not been getting care during this. And when we talk about health equities and disparities, we also have to realize that people were taking this seriously and staying home. For example, our treatments of strokes and STEMIs, or heart attacks, went down by 40%. I have a hard time believing that all of a sudden those disappeared. What I likely believe, or what I definitely believe happened, is that people did not get care. They were scared. That stigma, I'm having chest pain, maybe it's not so bad because I'm really scared of going to the emergency room because I might get COVID type of situation. And to be honest, there is nowhere in my mind that's safer right now than an emergency room, because we are now prepared. We know what is going on. Physician offices the same way, very much better prepared now that we're 2 or 3 months into it. So please, a key message that is very important as we talk about waves or spikes is that we have to take care of everybody, and we are prepared to do that in a safe way, not only for the people that are coming in seeking care, but those that are offering care or providing care. I'm sure a lot of you that are watching have someone in healthcare that you know very well. I mean, they are heroes and really have done an incredible job, and I thank each of you for that. And a shout out to social workers. I really, as we have gone out and done this, there couldn't be a more important role. And I think we will see social work and other types of healthcare deliverers or providers that we don't even have thought about using, we will be using. We've talked a lot about, Dr. Holt talked about the behavioral component. There's a lot of behavioral science and social anthropology that we have to take into account as we do our work going forward.
Thank you. Okay, moving forward, I know we're getting close to time, so I'm going to try to ask at least one more question. And the next question is, sorry about that. This one is addressed to Dr. Oliver, but anyone else can also speak on this. But it says, Dr. Oliver, can you speak to the contact tracers and how we see them getting into disenfranchised communities?
Well, two things on that. I believe that several folks have already addressed the fact that when you're doing work in a community, you have to be partnered with, joined at the hip with the respected and trusted community leaders, faith-based leaders, in particular in communities of color, I believe are really important for this. I also think that the contact tracers need to be people who, best possible situations if they're people from the community themselves, but at the very least need to look like and speak the language of the people that they're talking with. So as we've been recruiting staff and expanding our workforce of contact tracers, we've paid a lot of attention to ensuring that we have bilingual contact tracers, that we pay attention to recruiting in disproportionately high numbers African Americans, so that as we go out into those communities, people are seeing people like themselves who are asking them questions and so on. And I think the importance of partnering with trusted leaders in the community is that they can help sort of spread the word about the importance of doing this as far as containing the spread of COVID-19. And I'd love to hear what others on the panel would have to say to that, but that's what we're doing at the Virginia Department of Health.
Anyone else wants to chime in? If not, I'm going to move forward. Okay, I know it's currently, I have 7:28. This question comes from Emily Gordon, and it said, can the panel talk about what assistance there may be for vulnerable and underserved communities to gain better access to telehealth?
That's a great question. I know that we have, when we've begun to do our testing, we have worked with, in fact, local libraries, because that tends to be a place of resource where there are computers, and so people congregate there. It's been interesting to find that libraries have become a trusted place. So you can think about a telehealth booth in a library and begin to provide that way. What we are doing is that we are going to be creating telehealth mobile units that go into underserved areas, working with EVMS, in fact, as we think about it. Because a lot of work historically has been, okay, let me go out, take your blood pressure, and then send you somewhere. Well, the model we are now working on, since we've got this telehealth, is that I go out, I check your blood pressure, and instead of saying go see somebody, which doesn't happen, here, let me connect you right now. Here's the laptop, here's your visit, and then here's your medication, because I've tied it to the pharmacy. Here's a social worker that's working with me to try to overcome some of the other barriers you have. So I think our telehealth model has I would say advanced about 5 years in the past 3 months. And we're going to be able to use that after we come out of this to do things, hopefully, that I just mentioned. It is no longer just thinking about it. We now have the ability to do it and plan to.
Thank you. Well, I have that the time is 7:30. I don't know if there's anything else someone wants to chime in and say really quick. And I know we do have a few questions that are still outstanding that we can try to address at a later time. But I'm going to send it on back to Dr. Martin.
Thank you, Sherwin. Really appreciate you handling the questions for us tonight. And want to take time just to thank each of the panelists, Dr. Oliver, Dr. Holt, Dr. McNabb, Dr. Von Eden, and Dr. Asher. Your combined experience and knowledge and expertise was really helpful tonight to everyone. To those who joined us, just want to thank you for taking the time to do this. This is truly a public health crisis, one that, and public health is defined as community health. It's not our individual health that we're concerned about. We're concerned about our collective community that will help us protect our health. So there are things that we can do. We talked about some advocacy opportunities that you might be able to create, but there's other things that you can do, and that's to talk to your friends, your family, your neighbor, your network. When you're out, wear a mask. We wear a mask for other people, right? We're trying to help each other during this crisis. When you see people in need and you can help them, reach out to help them. Reach out to community resources and put them in touch with others. Reach out to social workers and nonprofit agencies and lots of the food bank, lots of resources out there that really want to try to help people. Together, we can, as a community of individuals, really make an impact on how this virus is affecting us as individuals and as populations. And we can do that with a goal of equality. And I'd like you to take that message with you as we close tonight. So thanks again for joining us. Thank you for the panel, and everyone be safe and well. Good night.